I would like to acknowledge the traditional owners and custodians of the land that we're on today. So I live and work on Gadigal land, but I was actually raised on the land of the Wiradjuri people. I pay my respects to elders past and present. So today's presenter is Gohar Yazdabadi. Gohar is the CEO of the Council on the Ageing New South Wales. So we first reached out to Gohar to discuss the State of the Older Nation 2025 report, which collected data from a nationally representative sample of Australians aged 50 years and older. And in our first meeting, it was really clear that Gohar was a passionate advocate for older people and whose policy making was really driven by collaboration with older people as well, including those representing diverse populations such as multicultural, First Nations, and those from the LGBTQ plus community. And of course, also collaborating with the wider sector as well, which is why Gohar did not hesitate to offer her expertise and time, which we really appreciate today. So today, Gohar is going to explore some of the key issues shaping ageing in New South Wales for women, including ageism and social connection. For our members, women over the age of 50 make up 35% of the clients attending a women's health centre or a special purpose service, making this training particularly relevant. What adds to the relevance is that Women's Health New South Wales and our members received monies under the Department of Communities and Justice, Sexual Violence Recovery and Healing Grant to run a project focused on supporting multicultural and older women recovering and healing from sexual violence. So that project actually officially started yesterday. So it's really great to have Gohar here to share these insights so early in the process. So, Gohar, I'm going to stop talking. The floor is yours.
Thank you for that very lovely introduction, and thank you to Women's Health New South Wales for inviting me to be here today. I'm really delighted to be joining you all. I'd also like to acknowledge the traditional custodians on the land on which we meet. I'm joining you from Gadigal country as well, and I'd like to pay my respects to elders past, present, and to extend that respect to any First Nations people joining us today as well. So I suspect that many of us today that are tuning in have spent a lot of our working lives thinking about inequity. We think about the social determinants of health, gender inequality, violence, economic insecurity, access to services. But sometimes when we're talking about women, we might not stop and ask ourselves, what happens to these inequalities as women age? Do they disappear? Do they lessen? Or do they become accumulated and become more pronounced? The reality is that the older woman is often carrying a lifetime of experience into her older age. The girl who was told certain careers weren't for her, the woman who stepped out of the workplace to raise children, the daughter who cared for aging parents, the women who experienced violence, the women who spent decades earning less than their male counterparts, the women who reached retirement in inadequate superannuation and limited financial security. These experiences do not sit neatly in the past. They shape how older women experience aging. And of course, they shape their health, their well-being, their relationships, and their opportunities later in life. I think that sometimes there is an assumption that aging itself is the issue, but aging isn't really the crux of it. The issue is that many women enter old age carrying a lifetime of accumulated disadvantage. And unless we recognise that, we risk creating policies and services that overlook the realities of older women's lives. So today I want to talk about ageing through that lens. So the conversation today will be about who a council on the Ageing New South Wales is, what I'm talking about when I'm talking about equitable ageing, and in particular how that applies to women, loneliness and older women, how older women experience ageism, and then the intersection of loneliness, ageism, and elder abuse. So, who is CODA New South Wales? We are an independent membership-based peak body for people aged over 50. It's consumer-led and evidence-informed. And essentially, what we're really interested in is advocating for the rights and interests and well-being of older people. We want to amplify lived experience, and we want to make sure that older people are able to drive the change that they want to see in society around them. So equitable ageing. At Council on the Ageing New South Wales, we've made a really deliberate decision to include equitable ageing as one of our strategic priorities for our organisation. So we've really been thinking about how we can enable equitable ageing. We did it because we recognised one thing that was really important, and that was not everyone starts aging from the same place. Older people are often spoken about as though they are one homogenous group, but the reality is that people's experiences profoundly shape how they will age and how they will be able to flourish in later life. Now, for women in particular, aging and equitable aging is really a very important issue because aging is often a culmination of decades of inequality for them. So they've spent a lifetime of lower earnings. They've spent time out of the workforce. They've got lower superannuation balances. They've experienced often discrimination, financial insecurity, housing, unequal access to opportunities. Then we layer other experiences on top of that. We see that many women may be living with a disability. They might be a renter. They might be a First Nations woman. They might be living in regional or remote areas. They might be part of the LGBTQI plus community. They may experience family violence. And these experiences don't disappear with age. In many cases, what actually happens is they become more pronounced as they age. So at CODA New South Wales, we define equitable aging as recognising that people experience aging differently. And for us, it's about ensuring that our work and our systems respond to those differences. So we all know that being older is a vulnerability, and we all know that women experience that vulnerability from disadvantage. We then know that those disadvantages that sit on the outside of the circle then all accumulate to make everybody's experience even more different. And what's really important about our approach is that it forces us to ask the question, who is being left behind? And that's the question we want to ask in all of the work that we do at CODA New South Wales. We know who our members are. We know who can access us. We know who can give us a call. But who is not calling us? Who's not contacting us? Who is being left behind? Whose experiences aren't being heard? And what are the barriers that are preventing those people from aging well? So I think this really is pronounced when we talk about loneliness. And hopefully the examples I give will sort of shed a light on that experience. So often loneliness is thought about as a social issue, but it's also a women's health issue, as you all know. It affects mental health. It affects help-seeking behaviours. It affects quality of life. It affects mortality. And we know that women experience loneliness differently. We know that women outlive men. So they've got longer lives and are often lonelier in those lives. We know that they are more likely to live alone in older age. We know that they are more likely to become carers and then lose their caring roles. We know that they are more likely to experience financial barriers to participation, and all of these things can contribute to loneliness in later life and then contribute to the physical and mental health of older women as well. So last year, or no, the year before, our research was on loneliness among older people in New South Wales. So just to give you a bit of an overview, we surveyed 2,200 people aged 50 or over across New South Wales. And to measure that loneliness, we used the John Gervald's loneliness scale, and that's an internationally recognized tool. And the findings overall were striking. 60% of older people reported experiencing loneliness, 50% were socially isolated, and 25% sat at the most extreme levels of loneliness. So the John scale is a scale from 0 to 6, and I'm talking about that 5, 6. It was the absolute highest level, and we saw 25% of people sitting at the highest level of loneliness, which is shocking in and of itself. But then we know that that loneliness isn't experienced equally. Just like we were talking about the circle that I had, we had, older people at the beginning, women, and then all the other sort of criterias that sort of can lead to more disadvantage or more vulnerability. We saw that with loneliness as well. So when we look at First Nations women, for example, and I think this is a really stark example, what we've got there is the number of people in the cohorts comparing First Nations and non-First Nations, where they were on the different points of De Jong's scale. And what you can see there is at the very end of the scale, where we're talking about the 6, we have Indigenous women reporting a 6 at more than pretty much twice the level of non-Indigenous women. That is an absolutely heartbreaking statistic, especially when the questions that are asked to form that scale are questions like, do you feel valued by society? Do you have somebody that you can contact? Do you trust the people around you? When we're asking these sorts of questions and we're seeing such a stark difference, it's really quite heartbreaking. But the heartbreak doesn't just occur at the end of that scale. It occurs at the beginning of that scale as well. So 0 are the people who have somebody to turn to, that they feel supported, that they've got people to be able to connect with whenever they need to, that they feel that society values it. And we're looking at something like 2% of Indigenous women feeling that way compared to over 10% of non-Indigenous women. And just to put it into scale, women were already behind men to start in this scale. So we have the general population, we have men taking a step forward from that general population, women taking a step back from that general population, and then again, First Nations women taking a step back from that population once again. So it's those steps that are being taken back that are very stark and very important. But it also is across other sort of indicators for women as well. This next slide looks at the percentage of women that scored the highest on the loneliness scale, so the 6, based on their income. And it's just extraordinarily clear. There's a clear scale that goes upwards. The less money that you have, the more lonely you're going to be. So again, those step backs that we're taking is really, I think, clear that this hurts differently, that this issue impacts differently, that this issue is more pronounced, and we know that it is a health issue when it comes to women. But what's really interesting here is the impact of loneliness. So this really struck me, and it always strikes me, is that 1 in 5 women told us loneliness had prevented them from seeing their doctor or seeking medical advice. Now, I think that's an extraordinary finding because it shows that loneliness isn't just affecting how people feel. It affects whether they raise their concerns, whether they follow up on their systems, whether they stay connected in the healthcare system. And for women, that matters enormously. If you're feeling disconnected, if you don't have someone encouraging you to make that appointment and checking in afterwards, it becomes very easy to delay care. And if we look at it not just from the women's point of view, but then dissecting that down to how must that then feel for First Nations? How must that then feel for women of culturally and linguistically diverse backgrounds? How does it feel for those on the lower end of the income scale? It all accumulates and makes things just that little bit harder. And making things just that little bit harder for someone means worsening conditions, pain going untreated, mental health concerns being missed, all of those opportunities of intervention that you guys do so well, that you guys are absolutely experts at, end up being lost. And I really want to see a situation where women aren't stopped from seeking medical advice because of that loneliness. So it really is important that for us at CODA New South Wales that we are advocating for the alleviation of loneliness amongst older people, because we know how closely it is tied to women being able to go and seek medical treatment, and how important that is to be able to also cut that cycle of loneliness. Because the less you see your medical practitioner, the more you are at risk of loneliness in and of itself becomes a risk factor. So it's something that we're very keenly talking about and very keenly pursuing. And that brings me to the next sort of lens to look through aging through, which is ageism. And really, ageism, it underlines everything that happens with aging for us. It is the the last ism that is accepted in our society. And it is a profoundly gendered issue. Women's value in society is often tied to youth, beauty, productivity, caring roles. And what happens when when women become older? Every day, I hear from our members that they feel invisible. And that really ties back to the loneliness we were talking about before. Loneliness, when we look at that De Jong scale, is really about being valued by society, having someone there for you. So this ageism and loneliness tie together very, very, very strongly. Older women often feel dismissed. They feel overlooked, and they feel like they're not being listened to or taken seriously. And that has implications for well-being and health. And the thing about ageism is that it's everywhere. It's everywhere that you look. Now, I have 2 young children, a 3-year-old and a 5-year-old, and uh, Bluey is often playing in the background while I am making dinner. And for those of you who don't know, it's a children's show, and it's based around 2 sisters, Bluey and Bingo, and they're cartoon dogs. And one of Bluey and Bingo's favorite games is Grannies. And they had an episode of Grannies once, and Bingo and Bluey's cousin comes around, and Bingo and Bluey are playing Grannies, and Bluey proudly says that she is kind Granny. And Bingo proudly says that she is hard of hearing Granny. And Cousin Muffin wants to join in. and they say, well, Muffin, I'm sorry. There's only two types of grannies. There's only hard of hearing granny, and there's only kind granny. Then the show goes on a little bit, and they think, actually, there's one more type of granny. There's grouchy granny. You can be grouchy granny. So, from a very young age, children come across this ism that they grow up with, which is ageism, and it sticks. And it is often Granny who is the portrayal of that ism within our pop culture itself. So the reason why I tell this story is that ageism is difficult to escape from. It is a cultural issue for us, and it's something that is so deeply entrenched that even beloved Bluey has succumbed to it. So, what is ageism? When we talk about ageism, we're talking about that stereotyping, that prejudice, or that discrimination based on age. And these elements come from the World Health Organization's definition. And really, we can see it in three different ways. And it's really important to recognize the three different ways, because there's ageism at the individual level, so everyday attitudes, language, behavior, and this includes, that those assumptions that we hold, like that there are only three types of grannies, or that older people are less capable, less adaptable, less interested in learning or participation, and that can really impact the outcome of any situation. There's institutional ageism, and that's where we see ageism embedded in systems, policies, and services. So the way that the system is set up itself ends up excluding older people, or maybe they're designed in a way that assumes that older people should have fewer rights, or that they have fewer needs, or that there are lower expectations. And then there's internalized ageism. Because we grow up with ageism from such a young age, and it's really pounded into us that ageism exists, and that we do just treat older people differently. We internalize it over time. So older people themselves have absorbed a lifetime of negative stereotypes about ageism, and then they start to believe that about themselves, and it stops their willingness to seek help. And a really good example of that is around depression. As we all know, a lot of older people just feel that depression is a part of aging, and that's just normal, and that's just how it is, because older people are just a little bit sad, whereas we know that that doesn't have to be part of aging. So ageism isn't just about those individual attitudes, it's also about structures, systems, assumptions, and all of those sorts of things. So again, we did a little bit of research on ageism. We surveyed 2,708 people, and they were aged 50 and over in New South Wales. So 62% reported being treated differently because of their age, and 40% experienced age-based jokes or comments. This study that we did really looked at exploring the question of what does ageism in everyday interactions look like, and how does it impact older people? And I'll go into that a little bit later, but it really became a stark reminder to us when we're looking at 62% of people being treated differently because of their age. That's a massive number of people. It's a very impactful way to live if a part of who you are means that you're treated differently by people day in, day out. An intrinsic part of you that you identify with so strongly, it becomes a barrier for you, which is very, very isolating. And 40% experienced age-based jokes or comments. But again, ageism is not experienced equally. So when we looked at First Nations, 72% experienced age-based discrimination. Again, when we looked at earning, 600, those that earned under $600 a week reported discrimination. And 37% of called respondents reported mental health impacts from ageism, which was much higher than the general rate. So these findings really highlight that ageism does not occur in isolation. It really intersects with other factors. And I'm going to give you an example um, of how it did so for women. Women were twice as likely to experience um, to experience ageism in a healthcare setting. Now, I think that that is a really stark reminder of why we have Women's Health New South Wales and why we have the services that you provide every day. Because in the general population out there, in the healthcare setting, the intersectionality of being a woman and being older is really stark and comes across really quickly. And the sort of feedback that we got was that, and you guys would know this really well, but my pain was overlooked because I was older. I was told that the experiences that I had was just a part of being a woman growing older. Um, I was not talked to when I went there. I was treated like a child when I went to see my healthcare professional. I was treated like a child. I'm not, and there'd be comments like, "I'm not a child. I'm a grown woman who can make her own decisions when it comes to the healthcare that I seek." So it becomes a really a really pertinent point for the medical profession. While women's health have this really, I think, down pat, it becomes much more of an issue for when your patients and clients are then going to see specialists or then going into the hospital system and they experience this kind of treatment. And they are most likely coming back to you and almost wanting the situation fixed. And I've had this experience in my own personal life when my mother was very unwell. Um, she was visiting an oncologist, and she had this wonderful oncologist that left, and then she got a new oncologist, and she had cancer, and her situation had gotten to a point where there was no treatment available, which is fine. We all know sometimes we get to that point, there's no treatment available. But the doctor said to her, the oncologist, the new oncologist said to her, "I'm not doing any more scans on you because I'm not treating you anymore." So what they essentially did was say that you no longer have the right to understand your progression and your disease because you're not going to be treated anymore. Now, if we were to take a younger woman who had children, I would guarantee you that an oncologist would not tell that woman that she will not have a scan to understand the progression of her disease, to be able to make the decisions, to be able to decide where to go next with her children or how much time she has left with those children. I think that that conversation would have been a very, very different conversation that was being had. And I think it often, because in our case, it often came back to the GP, to that primary level of healthcare for my mum, to sort of undo what sort of was done. And I think women's health plays such an important role in almost undoing that, but also in educating others and in educating other health professionals on what ageism for older women looks like in in healthcare. But ageism also impacts people differently depending on who perpetrates that ageism. And I think it's really important for us to remember that. Um, so we were able to look at both the short-term and the long-term impacts for different people where the sources of ageism came from. Um, and, when it occurred in families, the consequences were really personal and people responded with feeling less confident. When it happened with friends and acquaintances, it manifested socially with people withdrawing. In workplace settings, it was quite significant with people stopping their employment. Um, but when the source was a healthcare provider, the implications were quite, they really went beyond the interpersonal. Uh, what is very stark here is that the short term is that people um, uh, avoid coming back to that service provider. And 42% felt that their mental health or emotional well-being was impacted. The longer term consequences was that people felt less confident engaging with providers. So they felt less confident when they came into the healthcare setting. Um, which is why I think that primary services and organisations that cater specifically to women are so important because they can often help to reverse this. They can often be the provider that older women are comfortable going to, that they do feel confident in going to. And I think there's an important role in helping to bring back that confidence for older women once they do experience that ageism. Um, so I think what's really important is to remember that when a woman comes to see a healthcare provider, that their experience of ageism in the healthcare sector could be reoccurring and could be persistent, and coming to you is a beacon of hope that's not what they're going to be seeing when they're older women who've faced, sexism on top of ageism in the medical sphere. So I want to bring it all together because um, we've looked at that ageism and loneliness, but what the question really is what does it look like when we bring it all together? What is the importance of ageism and loneliness? Because it's something that's a really important topic at the moment, and that's elder abuse. These three things really live together and are very important to understand that relationship. So we know that ageism and loneliness both matter in the conversation around around elder abuse. So their interactions then show us how it becomes exacerbated. So if we start with ageism shapes the way that society views older people. So it shows up in assumptions that older people are less capable, that they're less entitled to autonomy and decision making. And these attitudes influence how older people are treated in their own families and their communities, in the workplace and in institutions. So then ageism pushes older people into the margins. Those margins could be the socially, economically, generally in community life. And by being pushed, what happens is that you have a contributing factor to loneliness and social isolation. And then we see social networks shrink. due to life's transitions such as retirement, bereavement, health changes. But the exclusion and the ageist attitudes then exacerbate this. We've seen ageism. We then see ageism push people into loneliness. And then when people are pushed into loneliness, we see social networks become smaller. Protective relationships are reduced. So people become more dependent on a small number of individuals for support. And there becomes fewer opportunities for others to notice that there might be something wrong. Um, and then these circumstances in turn uh, increase the risk of elder abuse. Elder abuse is really more likely to occur and harder to detect or report when we see someone experiencing harm, because they've got less connections with people who might be able to notice and provide support. And as we've seen, both ageism and loneliness can create situations where people stop seeing their medical provider. And that's one less person again who might be able to notice the changes or provide support. So it really becomes a very important social issue for us. Um, but importantly, that relationship just doesn't stop there, because abuse itself, so we've increased the factors of experiencing abuse, but then experiencing abuse itself reinforces ageist treatment, um, and it increases isolation as well. It then deepens loneliness and vulnerability. So instead of a chain of events, what actually happens is we see a reinforcing circle. Um, and it really is a reinforcing circle of um, inequity, and it is one that has significant consequences for older people in terms of their health, their mental health, and being able to reach out for that. Um, so, what it tells us is that to be able to recognize and address elder abuse, it's not just about responding to those harms after they occur. It's about addressing those broader conditions. It's about addressing ageism. It's about addressing loneliness. And it's about addressing them in a system where we consider inequity, especially amongst women. So I hope that you've enjoyed the presentation, and we've had a good look at ageism, at loneliness, and elder abuse. And while they are usually discussed separately and individually, they are closely connected in people's lived experience, and they shape how older people are valued and treated, in particular how women are valued and treated. Social isolation and loneliness reduce those connections and networks that help people stay supported and visible, including the network of their health network. And when those protective factors are weakened, it's when we really see that risk of harm increased. So let's stay in touch. You can go to our website, www.cota.newsouthwales.com.au, and there we have a section for providers, and you can subscribe to a bulletin that we put out quarterly. You can also find me on LinkedIn, Gohar Yazdabadi. I promise you, I am the only Gohar Yazdabadi that you will find there. Absolutely promise you.